Okay, so I said earlier that electron beams don't have a Bragg peak because they scatter a lot, but another thing that this does is it scatters our shaped field into our patient. And so in this example, we can see this is like a planar view, planning system view of a 10 MeV electron beam hitting a homogeneous media. This is the exact same beam shown two different ways. So this is like a percent depth dose, or I shouldn't say percent depth dose. This is like a dose distribution from a planning system. And this is the exact same data, but just showing the individual electron tracks. So this is obviously not all of them. Monte Carlo calculations have millions of electron tracks in them. But you can see what's going on here. This electron right here came down through the patient, took a turn, and went outside, and it basically creates what we call like an elephant foot style dose distribution. So right near the surface, the dose is very much constrained to the actual shape of the cutout that we have. But when we get deeper inside the patient, it splays out quite a bit, and we get this, I guess you could call this an inverted mushroom. Maybe I'll just start calling it an inverted mushroom. But some people call this an elephant foot type dose distribution where the dose bulges out quite a bit. This is like a good lesson for when you're setting up an E-beam on set. My favorite example, you're trying to set something up to treat something around the eye, and you think, oh, this light field is going to show me exactly where this electron beam's going. But what you're not seeing is that maybe just 15 to 10 millimeters deep inside the patient, that dose distribution is bowing out quite a bit and contributing dose outside where you think the field size or the cutout size is for that case. Here's the exact same data, just shown a little bit differently. This is like more traditional planning system data. The dose fall off changes with depth. So if we start right here inside this percent depth dose and we travel outside along this red line at this shallow depth, the dose gradient right here is much, much steeper than down here closer. I guess this is just a little bit past E max. This dose fall off is going to go much more shallow, and you can see low dose is spreading outside the field and the high dose is curving in just a little bit. So it's kind of going both ways. It's difficult to avoid some normal tissues. So this is a planning system view of a electron beam right at the patient's nose, obviously right next to their eye. There's some sort of compensating bolus in this plan, and you're attempting to basically keep the dose right in this area and make sure it doesn't get out to the eye, the lens, the optic nerve, the retina, things like that. So you just got to keep that in mind when using electrons. To this end, these days for treatment planning, we use electron Monte Carlo. Monte Carlo is much more accurate than the old methods. The calculation takes much longer, and there can be a lot of noise in it. So in this electron Monte Carlo, this is like the real data that the system does. It basically uses supercomputing power to produce this dose distribution, but this obviously is not what the patient actually gets. You do a lot of smoothing on it, and you get something that looks like this. In this example, this is a 9 MeV electron beam with a 15 by 15 cone. So electron Monte Carlo is used to do accurate dose calculation within the patient. These days there's really no substitute. It's really hard for us to take an electron Monte Carlo and then use the easier technique, or what we used in years past, like a simple percent depth dose calculation. Another thing to keep in mind with electrons is field matching. Field matching is difficult, and you have to be careful with it. You can have undermatched beams perfectly matched, and I'm putting perfect in quotes because it's never perfect, and you can have overmatched beams. So this is a weird example. This is a 19 MeV electron beam. So two 19 MeV electron beams, they're matching against each other. And you can see here's the undermatched beam. We call this undermatched because the dose at the skin surface is too low. This is 30, 60, 90% isodose lines. They're saying that these two beams are 1.5 centimeters gapped. So if you were to look at the light field of these two beams, they'd be about 1.5 centimeters apart. And you can see the dose that deep inside the patient is 120 because these two beams bow in towards each other, and the dose at depth sums up and contributes, one beam contributes to the other. The next one is the perfect match. This is a 1.0 centimeter gap, so we just move those two fields 5 millimeters closer. The depth here now is 40, 60, 90 is this one, and then 100. We're getting 130% dose increase deep inside the patient because those two beams are bowing towards each other. And I guess for their planning purposes, this was the perfect match, the best they could do. But then if you go to set up the patient, you were intending to set up a 1 centimeter gap and you did 1.5 centimeters instead. The dose at the surface is going to be pretty close to prescription, but deep inside the patient, you're going to get 150 dose increase deep inside the patient because the setup is so crucial. And you can imagine if we're treating like a cranial spinal radiation, the patient's spinal cord is at depth inside this match, and either the planning's not perfect or the patient setup is not perfect, you could really get 150 dose increase inside the patient. So it's one of those things. Field matching with electrons, very difficult. Physics has to commission this specifically. We have to do some measurements using film or something else to know exactly what the perfect match is. And then when we do patient setup, we really need the patient setup to be matching the planning situation as close as possible so we don't get this overmatching or undermatching, reducing the dose to our critical structures or overdosing critical organs at risk. And so this is what this looks like for like a cranial spinal treatment. So in this treatment, it's a pretty typical cranial spinal. You have this kind of whole brain field treating maybe 6 MV x-rays laterally. Unlike a whole brain field, this one's coming kind of low, right? It's coming low down on the neck because you have these two electron beams. So here's electron beam number 1 and electron beam number 2. And these two electron beams are attempting to match as perfectly as they can inside the patient's body. We're also trying to match this electron beam, which is coming PA, with two X-ray fields which are coming laterally. That's very difficult to match up. And so a lot of times what we end up doing is shifting these. So, these days we're using a lot more VMAT, but some places still use photon-electron beam matching, and we'll end up shifting these beams relative to one another. So we'll take maybe this electron beam, and so that we don't get the over-under match, we may treat like a field that's 20, and then we'll bump it out to 22 and then maybe 24 to fit it within a 25 cone. And then the photon field will shrink relative to that, and the other electron field here on the spine and down towards the sacrum will shrink away. So a lot of times the middle one will bump out larger, and the other fields will compensate to keep it all the same. And then that way you're feathering out. So when we do that, we call that dose feathering. We'll spread that out over 3 different plans for the patient over that treatment and feather that dose out. Another aspect of electron treatments for planning, similar to photons, electron beams show beam obliquity effects. So an oblique beam is one where in this diagram, if this is the patient's skin surface, we have this electron beam coming down and hitting that patient. I have three arrows depicting electrons. You'll get like this teardrop shape for each of these electron beams. So I have 3 teardrops overlapping. But then if the electron beam's hitting tangential to the patient, so instead of hitting straight up, it's doing like this, coming this way, you'll get this oblique beam, and then these teardrops are still happening. The physics is identical, but they're overlapping in a different way. So, you can get, because of this angle beam on a flat surface with electron, you can get normal beam on a sloped surface. So this can do things like increase the Dmax. So the Dmax may shift towards the surface. You may be thinking here that Dmax is at 1.5 centimeters deep, and when you hit oblique, it will pull that Dmax towards the surface. And then the depth of penetration will decrease as well. So you have to keep that in mind. Here's a depiction of that along with some homogeneities. So in this example right here, we have This is like a chest wall treatment. So here's the chest wall right here. This gray area right here is the lung. So that's our inhomogeneous area of the patient treatment. So this would be like CT-based planning. Back in the olden days, our planning systems were only good enough to think that all of this was water density, and it would show us this distribution like this. So here's 94% isodose line, here's 90, here's the 80%, which might be like the prescription isodose line for this electron beam. Coming to the modern age, we can actually do heterogeneity corrections. We can tell the planning system like this lung is not water density, it's maybe like 33% of that. And you'll get this very different dose distribution. And you can see here the weird thing about this one is in the areas that were basically unit density, like this part of the chest wall, look at this 95 isodose lines are about the same. The 90% is about the same, the 80 is about the same, but the big difference is in the lung. So maybe what we weren't seeing for so many years, we might have thought that the 10% isodose line was penetrating to here, when really it was penetrating much deeper inside the lung than we thought it was. And this is largely due to difference in density of the material causing different amount of electron scattering. And we call this basically like the coefficient of equivalent thickness, like CET. Another term that some planning systems call it is water equivalent depth. So coefficient of equivalent thickness, water equivalent depth, things like this. It's just kind of a guess of how much material you have to travel through to get to a similar thickness of water. So the attenuation of like some amount, z centimeters of slab material is equivalent to it. So you could take like some sort of thickness multiplied by its coefficient of equivalent thickness and get out what you think that distance is. And it says here the correct dose can be obtained from water data by using the effective depth. In this day and age, I'd say just use Monte Carlo to calculate it. I probably should have put these slides much sooner. So these are typical percent depth doses versus beam energy for 6, 9, 12, 16, and 20 MeV. Some characteristics that you can see here. Like you can ask the question, what is the posterior depth of the target? So that's basically our prescription depth, or D90. So here I'm striping this D90 through. We can pick off different depths to know what prescription we want to determine. Does the skin need to receive the full dose to the target? So if we're using a 6 or a 9 MeV electron beam, the skin may not be getting the full dose that we need. Do we need to bolus it? So if we're treating some sort of skin cancer right on the surface, we want to make sure that the very surface gets full dose. I may want to throw a centimeter of bolus on this patient. With this 6 MeV beam, we'll take it to about 90% at the skin surface. If I throw a centimeter of bolus on there, about the same for the 9 MeV, whereas the other beams like 12, 16, and 20, they basically are doing about 90%, whereas that's like 92% right at the skin surface without bolus. For clinical setups, are there organs at risk behind this electron beam? So if we're typically treating in the Dmax region of this beam, how quick does the dose fall off? You can see that the 6, 9, 12, 16, and 20, like the slope of that dose fall off changes. It's not dropping off as quickly as it used to. So that's another thing we need to consider when we use an electron beam. And so, we have all these data books. So every clinic should have, even in this day and age, an electron data book where it shows the percent depth dose and if the correct energy is chosen and this field size large enough and things like that. In our clinic, we have these tiny little cutouts. Like the tiny cutouts are kind of a problem for the dosimetry. So we have a whole data book full of small cutouts, and in this one we have like a 3 centimeter diameter cutout, a 6 MeV electron beam, and 100 SSD. And one of our doctors, he was always scripting these at 1 centimeter deep, so we had the output precisely located or precisely measured for exactly 1 centimeter deep. And this is the percent depth dose of a 3 centimeter circle, 1 centimeter. And this one we normalized it to 1 centimeter deep, not Dmax, because this is what it was usually prescribing to. And then you could just see like how quickly the dose fell off here in the practical range. The interesting thing for this is that as the size of the cutout shrinks compared to the energy that's being used, you will not get an electron beam that's flat in the middle. I suppose you could call this one flat. But right here at 1 centimeter depth, you're getting about 90% dose, which is pretty good across this patient. So even though you may think you're getting a treatment that is 3 centimeters diameter across, you need to keep in mind that the actual prescription isodose line only covers about 2 centimeters diameter across. So when you're planning E-beams or you're drawing them on set, you have to always leave that gap around what you want to treat versus what the cutout size is actually made. And in this example, you'd have to leave 5 millimeters. So if we were treating a tumor that was 2 centimeters in diameter, you would have to leave 5 millimeter gap around the whole thing and make a cutout that's 3 centimeters in diameter. 6 and 9 are typically used to treat skin lesions and things like that. For breast cancer, chest wall boost or scar boost or something like that. 6, 9, and 12 are used for chest wall treatments. 16 MeV is rarely used in the clinic. It's not often that we need an electron beam that's that penetrating. It's basically been taken over by VMAT. We decommissioned our 20 MeV a few years ago. It basically was very rarely used, and in this day of VMAT treatments, it basically hadn't been used at all. And one of the advantages of decommissioning a beam is we don't have to QA it anymore. Some machines will have a 4 MeV electron beam. It's used in some clinics for very shallow treatments, thin lesions in places of orthovoltage or superficial brachytherapy or things like that. Calibration of these low energy beams can be challenging because Dmax and field size dependent issues. Another aspect of electron beams is something called the virtual source distance. The output or fall off does not exactly match 100 centimeters source to access distance inverse square law, right? If you remember this diagram of the electron beam, the target's pulled out of the way. The electron beam passes through the primary collimator, hits the scattering foil, scatters from this position, so it's not scattering up at the X-ray focal spot or the 100 source to access distance or source to surface distance of the machine. And so we have this concept called virtual source distance, which is empirically determined. It's energy and cone dependent, and it's used to calculate monitor units for SSDs between your standard output tables. Most clinics will measure output at 100, 105 SSD, 110. I think we had some 115 measurements and things like that. But every once in a while, because of the planning system, we'd need to know what the output was at 102.4 centimeter SSD. So we had all these vast tables of virtual source distance. We effectively do this by doing some measurements to get an idea of what the inverse square law is for it, and then work the math backwards to find out that, for example, for a 6 MeV electron beam and the 15 by 15 cone, it appears as if the inverse square law is scaling from 86.7 centimeters for this 15 cone. And we had this vast table used to do calculations. The reality is, just use Monte Carlo these days. Don't try to. These calculations were okay, but we actually had a lot of exceptions when we used them. So all of these ones in gray we thought to be a little suspect, and we always wanted to get a measurement. So one of the lessons I have for electron beams is, if you're using them in kind of an unexpected way and off the typical use of them, just get a measurement, measure the output of that cutout, and then use that to know that you've done your monitor unit calculation correctly. And here's the formula that can be used for virtual source distance. So it's like output at Dmax, and the SSD that you want is the output at Dmax at 100 times. And this is just an inverse square law type scaling. Virtual source distance plus Dmax squared divided by virtual source distance plus Dmax plus the gap. And the gap is basically the difference between 100 centimeter SSD and what surface you were actually treating. So when you ran all through this, you could take this output and adjust it to this other output using the virtual source distance formula.